My name is Leslie Alfaro, and I am the program manager for Unshame California, which is like Joe said, an anti-stigma initiative working with Shatterproof, our national nonprofit, and then DHCS. So our goal really with DHCS or with this campaign specifically is to share videos of people who've been impacted by substance use disorder. We've collected, I think now it is over 70 stories in the past 2 years. And we've developed tons of content from that. You can go online. We have an Instagram page, a Facebook page, a website, a YouTube channel, and we share mostly through digital formats. So it is mostly through videos. We will share like pictures and quotes and things like that, but primarily we are a digital campaign. So like Joe said, really today, what we want to get to is some of that media messaging. So the things I'm going to talk about are really to set up some of the things and the strategies that we use. We understand that not every organization is going to follow these, suggestions, these actions, but we kind of want to talk about why we're doing them and the reason behind some of this framing that we're using. So before we get into any of that, I do want to talk about a little about what stigma is, the effects of stigma, the Shatterproof Addiction Stigma Index, and then go into some of that messaging information. So we always like to start out with, this reminder that stigma is this ever-changing thing. There is no characteristic that people hold that makes a person stigmatizing or not stigmatizing, because stigma itself is something that's ever-changing. It is something that's socially and culturally constructed, and it often reproduces inequalities and is perpetuated by the exercise of social, economic, and political power. So we often think of stigma as it relates to substance use disorder as this sort of very personal thing where this person has stigma and they're exhibiting that stigma and it's hurting someone else's feelings. But when we look at it from this macro perspective, we see that it really is much more than just one person acting against another person. So when we talk about stigma at Unshame California, we're really referring to 5 different areas. So we're looking at blame, we're looking at social exclusion, we're looking at prognostic optimism, which is the likelihood of recovery, we're looking at continuing care, and then danger. So each of these types of stigma kind of work alongside each other. So one thing that we always have to be careful about is that stigma can increase in one area while decreasing in another. So for example, we can look at something like blame, where someone is blaming themselves for having a substance use disorder, and that can impact the way that they're thinking about prognostic optimism. So we may lower stigma in one area, but then accidentally increase it in another area at the same time. So you really have to think about where are your priorities and who your audience is in order to make sure that the messaging that you're doing is going to be the most effective. One of the examples that we run into a lot is there's been tons of research that shows that having messaging around SUD as a medical condition will decrease certain types of stigma. But when we make those words too technical or too science-based, too medical, it increases the likelihood that people think that they're not going to recover. So kind of figuring out that balance of where it's going to work, right? So the way we kind of deal with that specific issue is, instead of saying it's a chronic medical illness, which illness is, it tends to be the word that people get stuck on, we use medical condition. So sometimes it's just tiny shifts, but just kind of to show that it is all a big picture that's playing into each other. How systems impact stigma. So obviously there's many different ways that stigma can impact all of these different systems. Like I said, it's much more than just one person, one individual. We know that in places like healthcare, when we looked at SUD treatment, 20, 30, 50, 100 years ago, it looked really different than it does today. And some of that historic stigma is still embedded in the way that people receive those services. So it was originally developed to be completely separate from mental health treatment and general health care. So we see that play out in the way that sometimes a SUD treatment facility will be a separate entity than the entire other parts of the health um, complex. We see that also with MOUD and MAC clinics. So they'll be, kind of hidden away in backs of buildings, or they'll be in the middle of warehouse districts. We also see it in language that people still continue to use. We hear this non medical terminology, so things like dirty urine or drug abuser, that still are used in medical settings. And then we also see it in media. So there's this exaggeration or misinformation that happens, the distortion and sensationalism of stories that often deal with SUD, where people are portrayed as either being, entirely helpless in the situation, or they're being portrayed as criminals who are only doing terrible things out in the world, rather than offering that opposite framing of hope or of, community. A lot of this does have to do with this complex nature of stigma. So we know that stigma is rooted in discrimination. When we're talking about discrimination, again, it can be this micro discrimination where there's that personal, social, interpersonal exchanges, but it can also be the big level macro discrimination where a person's rights are being violated, and this is happening at a structural, organizational, or policy level. So this shows up in the ways that insurance treatment or insurance companies will, uh, you know, pay for certain things. But if you have SUD, then they kind of look at it as a completely separate thing. They're able to deny coverage to people who have alcohol use disorders, or they're able to deny coverage if someone is drinking and they have an alcohol use disorder. So these systematic discriminations are the ones that really impact people more so often than that personal, although the personal is also terrible. I can also always spend, probably 2 days talking about the connection between race, ethnicity, and substance use disorder. But for here, we're only going to mention it briefly. This chart just goes to show that although people of different ethnicities and races often have very similar rates of substance use disorder diagnostics, there are often much higher rates of these overdose deaths. And we see that this has continued past COVID. So I know recently, we like in the past year, we saw a lot of these headlines talking about the overall reduction of overdose deaths and how the rates were going down. And this is definitely something for us to cheer about and be excited about this win. But when you start to disaggregate some of that data, you really start to see some of the gaps in how people are affected or how they are receiving treatment based off of their race and their culture and their ethnicity. So it's really important to keep that in mind, that it's a complex interplay between these things. And it really changes the way that people experience both stigma and the SUD. I mean, uh, the ways that they feel SUD and the stigma associated with it as well. We also see that there's differences in how people perceive the effectiveness of treatment. So, white respondents in a recent study, white respondents were more often likely to agree that there are effective treatments for opioid use disorder than Black and Latina respondents. There's definitely that racialized, stigmatized portrayal of addiction, where Black respondents are more often expressing this feeling that the media was unfair in their portrayals of individuals with OUD. Employer stigma and bias, where white respondents agree at higher rates that employers should be allowed to deny employment to individuals taking medications for opioid use disorder. And then just the overall lack of public support for Black individuals with OUD. Black respondents disagreed at a higher rate than any other race that their local government has strong policies supporting those individuals. And this one that I always like to put in a separate slide because to me is always just like, this is the one that we can't refute, right? Like it's not people having feelings about something, it is what is happening. So Black individuals are less likely to have their preferred type of evidence-based treatment due to provider bias. So in a recent survey, patients from the VA said that they were more likely to receive just methadone than also being offered buprenorphine in combination with their thing. So they're receiving different levels of care. And this has changed, with new legislation, but we do continue to see that there are discrepancies in how people are receiving that treatment. Um, Goals to consider in healthcare stigma is medications for addiction treatment for pregnant people. So there's that additional level of stigma that comes with gender as well. So when people are pregnant, how they're perceived by their medical professionals when they're already taking MOUD or MAT. We see that a lot with other government agencies as well. So people being judged for it. We've heard of cases where people have CPS called on them because they're taking these medications as part of their treatment. Along with that, parents in general have a lot more of that stigma. Pharmacists denying people for access to things like naloxone and other harm reduction tools. And then just in general, the healthcare setting employees. So when we think about these healthcare settings, it's not just the doctors, not just the pharmacists, the people inside the building. It's also the people that are outside, right? Like the security guards, the people that are neighbors to those facilities, and the stigma that comes along sometimes with having accessing these things. And then diving into the toll that stigma takes. So the effects of language. The language that we use can impact people in a variety of ways. It can impact policy making, employment, quality of life, and then overall self-confidence. And this plays out in tons of different ways. So we see in a 2020 study, people were asked about how frequently people did any of these things because they knew about that person's alcohol or drug history. So people saying, almost 30% of people saying they felt ignored or that people thought they were going to relapse. 20% of people saying that others thought they looked like an addict or that they got treated less favorably. It also happens in, more official settings. So people are avoiding them. They're rejected by friends and family. They lost their jobs. People leaving their treatment places because people there were treating them unfairly. And then looking at those ways in policy, right? So this is what I was talking about, where there's still state laws that permit intoxication inclusions in their insurance contracts. So if someone is intoxicated, they are able to be denied for certain claims, even though we know alcohol use disorder, relapses can be a part of people's journeys and recovery. So for them to be denied that coverage for a medical condition that they have is part of the ways that stigma has affected things like the public policy and the insurance policies are in effect. Then we have Shatterproof's Addiction Stigma Index. So the SASSY, as we like to call it, is a evaluation that was created as part of Shatterproof's work to measure beliefs around substance use disorder and see where people's beliefs, stigmas are changing. We had run it previously, but this most recent one was run nationally on March 27th, 2024, and included a sample size of 8,000 respondents. So these evaluations that happen are samples of the US overall. So they do tend to be, or they are representative, and we use that to sort of extrapolate information. So things like 3/4 of Americans believe that a person with substance use disorder is experiencing a chronic medical illness. So 74% of people in the US agree with that. 4 in 10 adults are unwilling to spend an evening socializing with someone who has SUD or to have someone with SUD as a close friend. So we see these numbers, which are pretty high, right? 44% are unwilling, and 48% are unwilling to have someone as a friend. We can also look at the bright side of 53% are willing to do that, but we really want to see these numbers be much lower in terms of that stigma that still occurs. 4 in 10 Americans believe that medications for opioid use disorder are just substituting one drug addiction for another. And about half would be willing to have a clinic that offered MOUD in the neighborhood. So the thing about these evaluations is we do, like I said, run these nationally every few years, but then we do have this information at a state level, depending on some of the states. So some states run it, some don't. California is one of those states. So we see pretty similar results. But one of the ones that we're always surprised by is that there is generally an increase in this second statistic. So it is a little bit higher in California that people would be willing to have a clinic that offered MOUD in their neighborhood, which is very promising for the work that many people do. 7 in 10 adults now support personally procuring naloxone, and less than half of Americans would support having safe injection sites in their community. So here we see that when we're talking about harm reduction, there are some types of harm reduction that have gained a lot of traction, while others can still be a little bit more contentious, right? So we're looking at this, we're seeing one type of harm reduction, that's great. The other one, we don't want that here. So we do see similar results in California as well. So overall, some key findings from this report, and this report is publicly available. So you're able to go online on the Shatterproof website and search the SASE and see the most recent report as well as some of the previous ones. We see that most Americans, 54%, know someone with SUD, that there is still a lot of misunderstanding about the nature of it, that Americans distance themselves from people with SUD, that people hold stigma towards some treatment pathways, and that there's mixed support for life-saving harm reduction interventions. So we look at healthcare again as a big one. We already talked about this. When we're looking at some of the SASE results here in California, this was from 2023. We currently are in the midst of analyzing the 2024 results. But the way that the evaluation works is the respondent will be presented with a vignette where they see a story about John, and John is either in recovery, so he hasn't used any substances for over a year, or he is in active use. So he is still currently using substances. And then we ask people, so at the baseline, which we ran in 2022, we see that people were a little bit more, or 42% of people thought that John was experiencing the normal ups and downs of life. At that 10-month, we see that 46%. Again, with these general labeling. So how likely is it that John is experiencing a physical illness? So this goes back to that like illness attribution, medical labeling. We see that at that 10-month across all of these, people are more likely to accept that it is a medical condition. When we're looking at public stigma, how likely would you be to socialize with John? Or how likely do you think that John is competent? We see again that increase of people willing to socialize and thinking that he's competent at that 10-month. And then that people are addicted to drugs should receive treatment instead of being sentenced to prison. So this is one where we actually see a slight decrease in California. And is one of those messages that we are continuing to push forward so that people really start to see that treatment option as the more favorable one. So only showing this to show that, some of the messaging that we have employed during the first 2 years of the campaign has been effective. And then there's others that just has not hit the mark as well with people. As of our recent campaign evaluation, we saw that approximately 5 million Californians were exposed to the campaign. And that's around 16% of people. So we're really excited by that number. And this is just one of those videos to show you all the type of messaging that we do.
I love doing like arts and crafts and stuff with my kids and, like painting birdhouses and making collages. Right now we're making fairy houses. Like we literally take like a watering can, and my husband will cut little windows and like doors in it, and then we like decorate it as though like the fairies found it and made it and then put it in the garden. 2 boys, 4.5 and 2.5. I love them so much. There's a lot of stigma about pregnant women, right? Active in their substance use disorder or even using MAT drugs. So I was already stabilized for many years on that medication, and then got pregnant, and I decided to stay on it because it just wasn't a possibility for me to taper off personally. I did experience some judgment and stigma while being pregnant and being on medication-assisted treatment during my pregnancy, mostly from my family members or like loved ones. It wasn't helpful. I understand it, but it wasn't helpful because I was not, in my case, I was not able to taper off. I want to avoid like a needed medication during my pregnancy, but that one was needed. And yeah, I couldn't even imagine. It's just, yeah, it's what I needed for me to get myself through and to be healthy and functioning for them when they were born. And they're thriving and they're healthy, beautiful little boys. I had no complications in my pregnancy. I loved my pregnancies. They're amazing. And my boys were born healthy and beautiful, and they're doing amazing today. And yeah, I'm very pro MAT in pregnancy especially. And I like to advocate for those women because I know a lot of judgment can be cast on them. I wanted to share my story because I want just, again, like the quest towards to normalize this. Tools to normalize medication-assisted treatment specifically, in that like professionals and mothers and people are on it and it's okay and it looks like this and it's good and healthy and it's okay.
So Jesse's video, the video I just showed, is one of the longer format videos. Whenever we post these on social media, we're splitting them up generally into 30-second to 90-second videos, just because we know that having those shorter videos tends to get higher view rates, higher engagement, just general overall people stay longer when they're short videos. And so I always want to share hers because it's one of those where there is a lot of stigma in that specific area, but we do generally still see pretty positive reception to her video. In fact, because of the video, she was also able to be connected with Women's Health magazine, and they ran a piece on her. And so just always sharing she has a full article. It's beautiful. Recommend everyone to go look at it. But one of the quotes that she said is, there was this medical provider who wasn't judgmental about addiction, and she was so nurturing and really cared about her. She was just different from other providers. And even when, we aren't providers, it's really the driving home the fact that we are able to make that difference for people simply by the tiny actions that we're taking. So the way that we're framing stories, the language that we're using, the images that we're using, it really makes an impact to people. And now Jessie is an advocate herself and has helped countless other women, all because of the way that she felt treated. Um, so now kind of digging into the action piece of it all. The first thing, the one that I'm sure all of you have heard many, many countless times, is language change. There is such an impact in language, and by changing language, by changing just the way that we say things, it can really have a really big impact on the way that policies are happening, the way that workplaces are existing, the messaging, and overall just the types of stories that we're seeing. So just a couple of things. Um, here are things that we can do as individuals, but then also start to implement in our workplaces and our day-to-day lives. So, always staying away from language that implies dirty versus clean. There's this sort of dichotomy that's often set up where you're either one or the other. And so when we say things like dirty urine, or are not clean, um, it really implies the other is also true, right? So when we're talking about addiction, we say, you have a clean test. It's like, yes, that's exciting, but also the people that are potentially, using again are then bad people. So staying away from any kind of framing that really sets up us versus them, right? And it goes into some of the other framing of the not in my backyard framing, which I know for us in California is pretty prominent. So by setting up this dichotomy in language, we reinforce some of these other policies that are really then used to exclude people. So it might be saying something, like this person is a drug abuser. Now that sets up two groups of people. And when people are talking about setting up a new clinic, we're able to use that sort of the bad people, we don't want them here kind of framing as a result of the language. So staying away from narratives that drive prejudice and discrimination is really important. Overall, one of those things that is complex within this conversation is that some of this language is still actively used in certain treatment pathways. So I know that, we're all familiar with things like Alcoholics Anonymous or other sort of groups like that. And they, at the very core of that work, say, they identify as addicts. And so even though we at our campaign don't refer to people as addicts, we always want to respect people's own use of language. So a person with a substance use disorder with that lived experience can use any of these terms: addict, drug abuser, alcoholic, dirty, clean. But when we're talking as health professionals or as professionals in the space in general, or the general public, we want to encourage people to say the more medical term. So person with a substance use disorder or being, having a misuse or problem with substance use, things like that, positive, negative test. And all of this is also, you can find it in our Shatterproof Addiction Language Guide. And the thing about that I really like about this language guide specifically is that it will have a note section that explains some of the background for why we use certain terminology. And I think that the thing to also just point out is this is the language that our organization uses and that our campaign uses, but it isn't going to work for every organization. So, kind of figuring out which of these pieces you want to implement into your work is also a key part of this work. So overall, consider using person first language. We always want to talk about the person and then talk about their medical condition. So instead of saying, that person is an addict, that person has an addiction, or that person has a substance use disorder. Honoring people's own language about themselves. So we can make as many guides as we want, but if someone says, hey, I want to be referred to as this, it's really important to honor how that person wants to be identified. And then this one is a big one because we know that, there's still a lot of agencies that do use substance abuse versus substance use. But for us, we again want to always reiterate that um, it is just something that people, substance use disorder is a medical condition. And, we had a speaker one time who said you would never say someone is like a food abuser. You would say they have an eating disorder. So it's very similar, right? We don't want to reinforce this fact that people may be misusing drugs. We want to talk about it as that disorder. And then the last one, calling in coworkers. Language change can be a slow thing. And so, one, offering a lot of grace for people. I think, especially when we're talking to a new story share, they always get really nervous that they're going to say the wrong thing. And it's not about always being right, it's about gradually changing our language. So, whenever you have a coworker that does use more stigmatizing terms, taking the time to call them in, right? Like, don't call them out, don't put them on the spot in like a super crowded room. Take them aside. You can always message them later and say, hey, by the way, you said this thing, and it's stigmatizing. So, just for future use, perhaps consider using this other term instead. So these tiny actions really build up to create that long societal change, which is what we talked about in those first slides. Advocacy. So consider advocacy around access to medication, but also just in general, right? Advocacy of services, advocacy of, just in general, having these conversations out in the open and people getting the treatment that they need. Things like advocating for more harm reduction services, and then also culturally humble care. Another one that we often practice, even at our own organization, is advocacy for internal policies. So, how do we talk about SUD in the workplace? And how do we make sure that we aren't just asking other people to do these things, but also holding ourselves up to these standards? And then the last piece of this presentation that we hold really, um, you can kind of see when you start to see more of the content, but framing is a huge part of the campaign. So we tend to stay away from any sort of more negative framing in the messages that we are conveying. We want this to be a conversation that includes everybody. And so we really try to incorporate that into everything that we do. So when you're thinking about your own work, thinking about how you can use framing theory to shape the message that your audience is going to receive. So framing theory in marketing suggests that the way a concept is packaged and presented influences the audience's attitudes and beliefs. So, how do we speak about and what type of stories are we sharing when it comes to addiction? And then, how does that influence the way that your audience is primed for certain conversations? Framing can weaken some voices while strengthening others, and it can invite the possibility of more complex emotional responses. So we often on our team will look at, okay, not just what does representation look like in our videos, but who are we framing as the experts of this conversation? And it's really important to us that we have a diversity of perspectives, a diversity of ages, a diversity of, race, ethnicity, and experiences. So there's people that have experience with medications, others that don't. There's people who, the parents who've lost children, or there's people that work in the space and have seen something many, many times. And making sure that that diversity is also framing people with lived experience of the experts of their own stories. So here's a couple of common story frames that we often see in as it relates to substance use disorder. If you turn on the TV right now, I'm sure you can find any one of these potentially being employed. The first is victimization. So, using language that really frames people with substance use disorder as victims, right? You can go on LA Times and it will be a story about how someone was suffering with SUD or they were struggling with SUD. And although that can make sense in certain scenarios, for us, it's really important to also highlight the hope. So we know that there's already a lot of messaging around that, but we also want to make sure that people have that prognostic optimism and feel like they have a fighting chance when they're looking at SUD. We also see things like exceptionalism. So this goes back to this NIMBY, us versus them. When we think about framing, it can be easy to say this one person is a success story and they are exceptional. And it's a really good, feel good story. But then it again creates this sense of if you're in recovery, you're a good person. And if you're in active use, you're a bad person. So, how can we instead frame things to be a community solution to bring all of us into it and make our successes communal wins, not just because this person was a really great individual, which can be true and we can point that out, but just keeping that in mind. There's also this issue of treatability. So how are we talking about, the curable versus incurable, or how are we describing different treatment pathways? And how are we setting them up to be, these are more favorable than these? We want to make sure we stay away from that and instead show that there's a variety of treatment options and that there's not one right path for everybody, but everybody is going to be individual and have those specific needs. And then the last one, which I still often struggle with, is this myth busting. So there's been tons of research that shows that when we employ myth busting as a framing strategy, people often walk away remembering the thing that we said was not true. So when we say, MOUD does not trade one addiction for another, MOUD is effective treatment. The part people remember is they're not trading one drug addiction for another, and they remember it as just they are trading one drug addiction for another. So it's important to think about how your audience is going to remember the messaging, and instead it's better to just deliver the message you want them to remember. For me, myth busting is always one that I like to go to because we see so many comments where people are saying things that are not correct. But like I said, people are more likely to remember the wrong message. And recent studies have also shown that lies are more like they're faster to spread online. So it's easier for us to just not go to that messaging that is a lie or the messaging that we're saying don't believe this. It's easier just to go directly to the message you want people to walk away with. Another big part of framing is the imagery that you're using. So it can really reinforce negative attitudes and beliefs depending on how you're using that imagery. So stigmatizing imagery can also be triggering for people. So think about, what images you're using and what message that image may be conveying. I know one thing we see a lot is like in newspaper articles, whenever there's a story about, substance use disorder, the images that we tend to see are like really dark, not enlightening, but in the mood that they're conveying. So what messages are you conveying that way? A couple of examples, right? So when we think about treatment and patient services, again, for some organizations, it may be helpful to use this type of imagery, but in other situations, it can be pretty stigmatizing to see these like very black and white, very dramatic images because it can convey that sense of hopelessness and that sense of I am alone. So just being mindful of what your images are conveying. So when we're looking at images, we tend to go for non-stigmatizing imagery or imagery that has more of this tone to it. It tends to be more focused on community or, the people that are in your circle that are helping you through this, or the sort of feeling of I'm not alone. And we do also know that it is people on social media tend to engage more with pictures of people. So figuring out how you can best use that to your advantage, right? Some of these images obviously are going to be a little bit more engaging than others because people like to see others' faces, but just being aware of what limitations you may have and working within that. Imagery around substance use disorder, right? So we see images that tend to be around centered on substances tend to create a little bit more of those stigmatizing beliefs. Images where we are painting a picture of what it looks like typically to have a substance use disorder can be really problematic because it can, one, lead people to feel this sense of personal shame, blaming themselves for a lot of this, but then also can create this idea that, well, this isn't me. I'm not on the street, so then I must not have a substance use disorder. I don't relate to this. So thinking about how you are portraying people and then also who might be left out of the conversation by sort of prescribing what it looks like to have this medical condition. This one is not my favorite because, again, this isn't as engaging for people, but it is a way for people to technically use this less stigmatizing imagery, right? Instead, focusing on that science, that medicine, that sort of more medical feel to things. But there's also different ways to portray this that don't necessarily go straight to showing pictures of pills or whatever it may be. And there are also sort of like a spectrum of stigma, right? Like if you have to use a certain image, this is going to be less stigmatizing than syringe, because we do know that people have stigmatizing beliefs around certain substances. So keeping that in mind as well, but making sure that again you're speaking to your audience and you know who they are. And then what does it mean to do your part? So there's obviously lots of things that each of us can do, both in the workplace and then just personally. So just a checklist of things that potentially you all can think about as you go on about your days. But what are your language choices and how are you potentially having stigmatizing things put out there? I think one of the things that, no one ever wants to hear is that they themselves hold stigmatizing beliefs. But I think it's really important to acknowledge that we do have stigmatizing beliefs and that there are things that we can do about it. I know for me, I often find myself having a reaction to something. And then I think to myself, why did I have that reaction? Oh, it's because I hold stigma around that thing. And really actively thinking about what are the ways that I can change that for me. Looking at the way that you frame external materials and also internal materials, right? Like I know today we're talking about this messaging piece, but how are things like your website set up, your one pagers, your social media content, even things like, your anything intake forms, things like that, where you think there might not be any stigmatizing language. Sometimes it's good just to do another look and see if there are potentially any things. I know for our campaign, when we set up the website, the first thing that you saw when you came to our website was this many people have died in California from overdoses. And our goal was to be really shocking and to get people to like want to act. But we realized that instead, some of the actual thing that was happening was that anyone that came to our website, the first thing they're seeing is this many people have died. And this is something that is really almost an unovercomable obstacle. So, like, it's going to be really, really hard to do anything about it. So we changed that to be more hopeful and instead to be quotes from different people sharing their stories of how much better their life has become. So conducting an internal audit, not just of policies, but again of the materials that you're using. Organizing trainings for staff, right? Like this is a smaller group, but there's so many other trainings that are out there that are going to be specific to the type of work that you're doing and the type of experiences that you may be having. calling others into the conversation. So I find myself even in my day-to-day life, kind of educating people on some of this stuff, and it really does make a difference. Then you start to have these, conversations, and people come to you for resources and things like that. Uh, Creating educational materials. So, like I said, you know your audience, you know what's going to best speak to them, and making sure that when you're doing that, you're really thinking of them as who you're directly talking to. And then the last one is share your story. So, as part of our work, we're always collecting new stories. We are always
We're still human.
Oh no, we're always collecting new stories. We're always, going out to interview people. So if anyone is interested in sharing a story, either as someone with a lived experience or as someone that works in this space, we're always happy to set time up to talk about that.
We're still human. We're someone's father. We're someone's brother. We're someone's son, someone's loved one. And that, at the end of the day, that's what matters. I mean, if people are struggling, and instead of having that stigma and try to beat them while they're already down, why not take the time to ask, how can I help you today? Whether it's addiction, whether it's diabetes, whatever it may be, someone's struggling with, guess what? That individual is someone's loved one. I mean, let's not focus on the problem. Let's focus on the solution. I went into treatment right after incarceration, and I had some time away from the substances while I was incarcerated. And it's going into that transition into treatment. I went into with an open mind, that willingness to change, mainly for myself, but for the betterment of my family. At this point, my relationships are they're awesome with my kids, my families, friends, new acquaintances, coworkers, that I get to be present. And if I'm not feeling well, or so I'm a little off today, guess what? I get to communicate, share that with somebody, and get feedback, and take that into consideration, and just grow on a daily basis. Every day, someone steps into my office asking for help. That's with open arms, being sincere, just meeting the patient where they're at. What can I help you with today? Let's all work together as eliminating stigma. We have to work together. It's all about giving opportunities whenever possible. Just keep an open mind, show that willingness, and let's move forward, forever forward.
And these are just some of the faces of some of our story sharers, but we have so many, and we're always excited to add more. So I'm putting up my email address if anyone is interested in reaching out to me. We also have our Instagram and Facebook accounts here if anyone wants to follow.